What we're finding now is that many of our patients coming in diagnosed with diabetes, hypertension, any kind of the chronic diseases, they also have an underlying problem with depression, or it's just an overwhelming burden for them with everything else they have to deal with. They need mental health counseling. So there is a move afoot in the primary care among the community clinics to look at that integration of mental health services into our sites, and that's really a key component, that it does need to be there. It needs to be in the health reform legislation, that there's this collaboration and integration between the providers in mental health and in primary care.
Okay. When we're looking at Latino populations, we're also looking at Spanish-speaking primarily, Spanish-speaking population, immigrant population. And I think that, if we really wanted to get to the root of healthcare in non-English speaking, we should be able to look to our folks in the southern countries, to the mother countries, to try some pilot programs. This is just an idea. Pilot programs by where we bring over interns who are working in Mexico and Central American countries in mental health, to be able to work and to facilitate the work here in the United States, so that they are targeting people of their own community, their own culture, because we definitely have a shortage. And that shortage should be identified in healthcare reform. And then we need to find a solution to that problem, because it is a huge problem. And the second thing I wanted to add, real quickly, I think it's really important when we're looking at mental health and substance abuse, is that we take on the tip from this current administration and the leadership, and really start including tobacco use as an entrant to the alcohol and other drugs, because tobacco really needs to be put on the front line of the substance abuse issue and preventative care.
Half of the students at Cal State Northridge, of undergraduates, are about to become Latino. Excuse me? I mean, not become, but will. They're going to hit they're going to hit the 50% mark. There's no pill that they take for that. And the reason that's interesting is that I remember when I graduated with my PhD, I was the only Latino, in a class of 50 at Claremont. It's not translating into graduate school. And we could have a 5-year plan to move that number into graduate schools. That could relatively immediately, have an effect on what's going on. So there's hope.
And I think some states, particularly California, were already starting to do this, is actually develop standards for what it means to be an addiction specialist or be a mental health specialist, developing standards so that people are clear that this is actually a field that you can go into and that there's a job trajectory. In other words, I can start at this space, but through additional education, additional training, I can move in this field and actually make a living wage working in this very difficult field.
That's a very important issue for us here in California. When you're looking at a reimbursement system being established at the federal level. We do not have reimbursement for marriage and family therapists because it's not a universal across the country specialty. And so by focusing on the skill level and regardless of what the title is, can help us solve that problem here in California, because frankly for us of color, the majority of our health professionals are marriage and family therapists. And yet we employ them because we need to, but yet we can't get reimbursed. So if we're focusing, I worry that we'll make that same mistake because we have not been successful at the state level to get those health professionals covered as a reimbursed service. It worries me if we continue that problem then at the federal level. So by continuing to focus on just a title, in terms of who's able to be reimbursed, we'll continue that problem.
The chronic, reoccurring nature of these issues the need to be able to keep people in the system over long periods of time for reoccurring kinds of things. Ongoing case management, which leads to the workforce issue of are there people to handle this beyond the highest trained kinds of levels, the same kinds of workforce issues we heard before. The aging of the workforce in this area, the particular difficulties maybe of getting people into it, be it Latino or otherwise, whether that's financial or I suspect stigma or attractive issues or challenges. The fact that there's a lot of people who are recovering in substance abuse, I would just question, not to be answered here, is do we need to encourage more people who are not recovering? Do they add something?
Yes.
Or is this the, and what is that?
Absolutely.
And how do we deal with that? Incentives for financial, other for nurse education to get more people to teach in these areas, public health, emphasis, the problem of psychiatric or psychology residents having to pay rather than get paid, integration of mental health into the services, a particular shortage of Latinos in the field, pilot programs, connecting tobacco to some of the other things. I was thinking similarly, I mean, you see all these ads about, if you want to try public relations, all these ads about depression, right? I don't see ads about schizophrenia or other kinds of mental health about which we have more. We're also used to depression, maybe we can sell it to people as a problem, right? But when it comes to some of these other things, nobody wants to touch them. And they're very expensive, I think, so the issues there. Finally, it struck me, this whole local thing, I would put on the table, to what extent are some of these things national and local? I would think in some respects that California may be more progressive, I would guess, no? Than other states, than some other states. If you try to do some of the things nationally, you're gonna hit some other states, maybe I'm wrong. Okay.